Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Okay, Doc community, this is a big one. This is not only the 150th episode of the Doc Podcast, but today I'm joined by a true legend in the field of pediatric sleep medicine, Dr. David Gozal. Dr. Gozal is currently the Dean of the Joan C. Edwards School of Medicine and Vice President for Health Affairs at Marshall University in West Virginia. He completed his pediatric pulmonology and sleep medicine training at Children's Hospital Los Angeles, and shortly thereafter joined the faculty at USC and UCLA. He went on to serve in leadership roles at various leading universities, including University of Chicago, Tulane, University of Louisville, and University of Missouri. Dr. Gozal is past president of the American Thoracic Society, becoming only the third pediatrician to be elected to such high office. He has served as deputy editor-in-chief for the journal Sleep and associate editor for the European Respiratory Journal, Pediatric Pulmonology, and several other journals, including American Journal of Respiratory and Critical Care Medicine. Among many of his awards and accolades, he was the recipient of the ATS Amberson Lecture in 2002, the William C. Dement Academic Achievement Award by the American Academy of Sleep Medicine in 2013, and the 2016 Lifetime Achievement Award of the National Sleep Foundation. He has also been bestowed 2 honorary doctorates from the University of Barcelona and the University of Lleida in Spain. Dr. Gozal's research has been continuously supported by grants from the NIH since 1992. He has published more than 930 peer-reviewed original articles with more than 95,000 citations, earning him the distinction as one of the top 1,000 most cited scientists and one of the top-ranked investigators in medicine throughout the world. As if that's not impressive enough, he has authored nearly 200 book chapters and reviews, edited 7 books, including the reference textbook in pediatric sleep medicine, presented more than 1,250 scientific abstracts, and has extensively lectured all over the world. I think it is safe to say that his academic resume is nothing short of spectacular, and you do not want to miss our amazing discussion on pediatric airway disease. Also, if you're enjoying the content on the Doc Podcast, we would love to receive a 5-star review on Apple, Spotify, and YouTube if you feel we've earned it. And please continue to share the show with friends, family, and colleagues who you feel could benefit from hearing this important information. So without further ado, let's get on to today's episode with Dr. David Gozal. Enjoy the show, everybody. Welcome to the Doc Podcast, David.
Hi, how are you? Good to be here.
Thanks so much for joining me. I know with your schedule, it is not easy for you to carve out time. So I truly appreciate you taking the time for the show and for the audience. Before we get going into some of the cool things that I am really excited to talk to you about, tell the audience, if you would, a little bit more about your background, your history, and how you got to this point where you're now dean of a major medical school.
Well, first of all, thank you for having me again. And well, I started my career a long time ago as a medical student. After doing a physics and math major in college, I decided that Albert Einstein was going to be an impossibility, and so instead I went for Albert Schweitzer, with really the intent of serving underserved communities and being able to contribute to the developing world in the emerging economies, because that's where, at the time, almost 50 years ago, that's where most of the problems in access to medical care existed. Not that there weren't any others anywhere else, but those were the obvious ones. It was the time of Biafra and the times of hunger, very starvation. And so seeing those pictures as a young man really triggered the sense of responsibility and accountability. I moved forward. I went to medical school in Jerusalem, and then underwent training in pulmonary medicine in Paris, followed by pediatrics back in Jerusalem and Haifa in Israel, and then spent time in Africa developing rural healthcare programs, primarily in Cameroon, in West Africa, for about 2.5 years, a program that ultimately still exists and is still functional, and which, of course, I'm very proud of.
Neat.
And then, like everything else, you come into a stage of a career where you say, I'm tired of arguing with myself and being always right. And so I really wanted to delve a little bit into research. I had the opportunity of doing some self-driven research, but really nothing that would compare to a career that would be based in a strength, organized, and so on. So I came to Los Angeles as a fellow, to Children's Hospital Los Angeles. I did a fellowship in Pediatric Pulmonary and Sleep Medicine, as well as neonatology. And that's where really I launched quite a bit of work. I was interested in sudden death and death syndrome due to an event of a baby who died during one of my being on call in the hospital. I knew that happened during sleep. I knew nothing about sleep because medical schools don't talk about sleep. So I thought that maybe this is a part of the world telling me something. And so I wanted to really study sleep, and particularly during the developing child. And so that's why I came to Los Angeles. There was a great group working on sudden death and death syndrome and apnea. And from there, it was only a matter of, the United States has this unique ability to induce physicians or to attract physicians that want to do the tripartite mission of, clinical service, education, and research. And so I felt that I was in Toys R Us, that I could do whatever I wanted and play with any toy I wanted. And so that's 35 years or 37 years later, so I'm still around. The career was just a matter of what I call luck and finding the right people that taught me a lot of things and taking advantage of what they could teach me to maybe push the envelope a little bit further. And so I've had appointments at both USC, University of Southern California, UCLA, Tulane, University of Louisville, University of Chicago, University of Missouri. And in the last 3 years, I've had the honor of being selected as the Dean of the Medical School here at Marshall University, at the Johnson Edwards School of Medicine. And we're trying to create a little bit of a trailblazer change for both our medical school, where sleep is now taught, but also to, foster the service to the community in many different areas. You come to realize that even in the United States, there are areas that are clearly underserved. Many rural areas are still underserved. And so this is obviously a mission that all of us need to stand up and deliver. And so that's what I'll try to do until I retire, hopefully in a few years, if health and everything else will allow. But in the meantime, nothing like having fun, waking up every morning and feeling that you're challenged, that you're doing good things, and that you're preparing a sustainable model for the future with a lot of people that are going to deliver that goal. So anyhow, that's pretty much it.
Wow. Well, thank you for encapsulating that. And it's interesting because even though I know a fair amount about you from reading about you and reading many of your publications, and thank you for your help on the joint venture, the manuscript that we're working on together. And I really appreciate your help and insight. It was really invaluable to have someone such as yourself there to help me navigate through some of that. Interesting. I didn't know about your affinity for really working to find alternative solutions and find solutions and alternative solutions to helping the underserved. And I think that's a really interesting underlying theme of your career, just listening to you speak. You mentioned it from the very beginning up until now, what you're doing as dean of a medical school. And I love that because it is, especially as mentioned in the rural communities. I'm down in Collier County in Southwest Florida. It is in Naples, Florida. People think of it as just pure affluence. There is a tremendous amount of poverty down here in our rural communities. And I'm working in my current capacity, helping build an orthodontic component to a pediatric dental residency where really it's a federally qualified health center, and it's almost predominantly all focused on treating the underserved. So it's such a need. So thank you for doing that and for continuing as you continue through your career for focusing on those communities that don't get the care. And it's a really tough challenge. I was talking with the director yesterday and some of the admin, and it's a really tough challenge. There's no easy solution to that. So it's something that's much needed. As a quick aside, is there anywhere in particular you think that came from? I know you said seeing the kids with SIDS really had an impact on you and the starving children in Africa. Is it something in your upbringing maybe, or is it just something that you just kind of had a predilection for?
That's a tough question. I think it's a little bit of everything. You have role models during your early life, parents, uncles, friends, others, teachers. your primary care physician, and then, you develop a certain affinity for certain elements that touch you, right? And it's just really, I think that the issue of vocational training and being brought up into a world that at the time, this was hippie time, this was the beginning of Woodstock and so on. So this is really a time where a lot of these concepts of peace and love and brotherhood and so on, really as a young man evolving in that environment, seemed very, very important that you bring to society and contribute to society, not just for their own self, but by giving. And so I learned one very important thing very early on, and that is that giving is addictive.
Yeah.
And that is a very important concept. The more you do good, the more you're addicted to doing good, and the more you want to impact even more people. And if you see through the whole history of mankind, people who have had this unique initiative of giving even a little bit become really very attracted to giving more and understand that is a much more important impact than just taking for yourself. So whatever we do, and I applaud your efforts to do what you do in your community, I think that we shouldn't forget that a distribution of wealth is not necessarily Gaussian, first. Second, there's always the have-nots, and those usually overwhelm in number those that have. We talked about the 5% and the 1%, but we never talk about the 40 or 50% that barely can put food on their tables and they go hungry sometimes. Yeah. And so when you go into those communities and understand that in order to have them healthier and to be productive and to be able to function, you need to give them education, they need to have access to health. Those are two elements that go together, and those are the two pillars of any very successful society.
Yeah.
So as part of that, medical school or anybody that is involved in anything related to health or education and academics should think of these two pillars as the drivers of economic prosperity. If you do that, then economic prosperity will come. And so why not work at the pillars rather than work at everything else?
Agreed. Very well stated. I agree. So as we dive into the discussion of pediatric sleep medicine, pediatric sleep disordered breathing, it is something that we talk a lot about in the dental world, in the orthodontic world. And I often say to my dental and orthodontic colleagues, I wish you could all hear someone who's really an expert in sleep medicine speak on this issue. Someone such as yourself and other guests that I have on this show. That's one of my passions and reasons for this show, is to help educate all colleagues, but especially those who may not have access to this type of information or have the time to go look for it. If you were to try to encapsulate one or two areas that you feel are most lacking in the general knowledge within, let's just say right now, the dental and medical professions, when it comes to pediatric airway disease, what do you think those would be?
Well, the first one is that we're not talking about a single disease. And so I think it's important to think in concept that phenotypic variants, so the multiple presentations, may underlie different mechanisms that leads to a priori or what would seem to be a similar result, right? And so let's keep that in mind. That's the first one. The second one is if you understand the determinants of all of these diseases, the important component is what constitutes a disease. So starting defining disease is very important. I don't think we have reached that consensus, by the way, but we'll talk a little bit about it more as we go into the program. And the third one is a disease is only, you can have, for example, snoring. Snoring is not normal. Let's make it clear. It's not a normal pattern of breathing. So anybody who snores has increased upper airway resistance. It doesn't matter whether it's causing any end organ dysfunction or not. But the important component is that a condition can only be called a disease, or a symptom can only be called a disease if it causes damage. Tissue damage, organ damage, and therefore I would first start conceptually thinking of sleep apnea and sleep disorder breathing in children and adults as a chronic, low-grade inflammatory disease. Now, if you put that, now you start understanding. And now, if you want, I will put in parentheses a lifelong. Lifelong. Not just a condition that is a chronic condition with low-grade systemic inflammatory processes, but also a lifelong disease. Now, if you put it all together, now you have a very complex problem that starts very early, maybe even before birth, likely before birth in many cases, has different manifestations in the sense that different drivers will cause similar phenotypes. And those phenotypes will manifest as morbidities that are very different, with some degree of this variability being very important to understand because that defines priorities for both prevention, intervention, and overall outcomes. So once you put it that way, now you have a compounded elements of Venn diagrams of multiple spheres that interface with each other. And there's not a single one that is isolated and lives out there and you say, wow, it's so easy, right? I know exactly what to go and exactly what to do. Because it is a combination of multiple factors that come together, each of them with different proportionalities into every kid or into every patient. And therefore, to start understanding those, you need to define what are the determinants of disease, or the determinants that leads to the susceptibility to disease. What is the disease? Why is the disease manifesting in the particular patient? And what are the elements that need to be intervened in order to palliate, prevent, or mitigate the effect? And then finally, there's a very important one that we tend to assume. We are very naive in medicine, and I'm assuming that also in dentistry because I work with a lot of dentists. And one of the things that we say is, well, if it's broken or if it's semi-broken, we can fix it. And once we fix it, everything should be fine. In other words, you assume that reversibility is universal. And I'm sorry to disappoint a lot of people. We'll talk about what I call the second best hypothesis, and I'll explain, if you don't mind, I'll explain a little bit about it when I talk about reversibility.
Yeah, absolutely. I love how you laid that out because oftentimes I find that we don't fully know enough about the disease or the severity. I feel like you said, the traditional adenoid facies. We get in this big argument in the orthodontic world, at least, of whether or not adenoid facies is even a thing. And I think that gets into that variability in phenotypic expression that you were alluding to, right? Not every child with disease is going to present in the same way. Not every level of disease is comparable. And we tend to want to, especially in the dental arena, and correct me if I'm wrong, I would guess probably in the medical arena, we want to put things into certain categories. We want to put things into identifiable labels. And when you have this disease that is multifactorial, heterogeneous, hard to quantify, hard to diagnose, especially when we don't in dental get really any training in this at all. And then we get out there and we start learning more about it. It seems very overwhelming. So I feel like we almost try to oversimplify it in our minds. Like, well, if they have an AHI of 1 or more, then I worry about it. And if they don't, then I don't need to concern myself with it. So I'd love to hear your thoughts on whether you agree with that we've kind of oversimplified this. And if so, or I guess even if not, where do we go to try to help educate all medical and dental providers? Because as you alluded to, there are a lot of physicians that are not well trained in this area as well, to help them to see and understand the spectrum of this disease, of this pediatric airway disease, the spectrum that it is, as well as the different diagnostic and then ultimately treatment parameters that are impacted by that complexity. Have you heard about the Doc Community on Facebook? It's where you can get access to more great content, including case reviews, select clips from CE courses and podcasts, literature reviews, and exclusive promotions and discounts off Doc educational materials. Just go to Facebook and search for the Doc Community and submit a request to join the group. And now back to the podcast.
Okay, well, that's going to be a lot of talking, but sure.
Well, you're the expert. You go as long as you need on it.
Good, no problem. So let's talk first at the end, because I think that ultimately that's what we want. We want to fix and reverse as much as we can any potential damage that is being caused by any disease, right? That's the important part. You restore function. You restore homeostasis. And those are the important factors. And so the first question that arises is, and if there is already any type of morbidity, and we're going to talk a little bit about what they could be, are these reversible? Is this morbidity reversible? And the reality is that it's a very important, very complex question, because it has to do with both severity and duration of disease. So the longer you go, the more damage is going to accumulate. And the likelihood of already having used a lot of the reserved mechanisms that you have in your body to fix whatever is going on is going to be relatively limited. So, for example, you have oxidative stress, you have inflammation. Okay, inflammation is going to cause damage. Oxidative stress, you have antioxidants. But there comes a time that your antioxidant capacity it's going to be exceeded. You're going to have damage. That's what it means. Okay, that means that your antioxidant capacity was not sufficient to prevent all of the consequences. So even if you remove it, that damage is already there. So what repairs those damages? Well, some of it has to do with the recruitment of stem cells. We have stem cells in our body, and you can rebuild systems. That's what our bodies do. Then we have the problem is that in certain type of kids or in certain type of adults, we see that the response of the stem cells that are recruited is not as good as in others. So your inherent capacity to recruit and mobilize stem cells to the area of injury may, in fact, limit your ability to reverse an endotype result and then go the damage that you're being into. So that's one possibility. The other is that relates to the chronic low-grade systemic inflammation. Is that any chronic low-grade systemic inflammation essentially accelerates aging and accelerates cellular aging. So we've done some work, obviously, in mice and in humans, particularly in adults, and we have shown that sleep apnea indeed accelerates biological aging. And so how do you reverse biological aging? There's billions of dollars being invested in the industry of aging and preventing aging at the level of organisms. Why is that important? Because everybody wants to live to be 150, 160, and live well. Let's not just live to that age, but live well. So there's a lot of understanding of what these biological mechanisms of aging, and we know quite a bit. And we have shown that, for example, if you remove cells that have undergone what we call senescence or accelerated aging, and we remove them with specific genetic targets in mice, of course, there's all very, very functional and very well-designed experiments, you actually can accelerate the recovery from having sleep apnea and so on. So, okay, cool. So on one hand, I promote stem cells that repair and build the house back. On the others, I take away the bad cells, the bricks that are kind of damaged, because otherwise the foundation is not very good. And by doing this, I can really cause recovery. So that may work for tissues like the fat or the cardiovascular system, the vessels maybe. But the brain, for example, is different. If you have killed a cell, a neuron cell in the brain because you have sleep apnea, you have what we have termed now many years ago, the second best hypothesis. You have a circuit, and let's say you have a chip. Your brain is a chip, right? Computer chip. And you have 6 neurons in it that work together, and that chip works beautifully. It's a very high power. In other words, you have a very high IQ, right? So you're probing, you take a problem, you solve it very quickly, not a big deal. You get more complex problems, and the chip works beautifully. But then let's assume that one of those neurons, one of those connections in the chip is now damaged. And instead, you're putting a second best. The brain is now, through stem cells, identified the new neuron that is now plugged in into the system. Well, maybe the chip will be continue functioning the same way. Wow, you learned lucky. But maybe not. So now instead of really working at a very high capacity, you have lost a few IQ points. So for simple problems, you may not see any difference, because you may take a little bit longer. Instead of 2 milliseconds, it will take 5 milliseconds. Big deal, who cares, right? But when you start putting more complex problems, that will explain the difference between going to college and not going to college. No, it's too late. It's 15 years later. Whoa, what if we could reverse it? And so how do we identify those? Very complex. So that some studies have looked at MRI, looking at gray matter. We know that gray matter is lost. We showed it already 12 years ago. So that's worrisome because these kids have normal intellectual capacity, normal intelligence, normal cognitive function. So these were kids with sleep apnea that have normal cognitive function, yet their brain showed that they had lost very much. Second, that in order to solve the same problem that another kid would need only, let's say, 1% of the brain, just to be an example, they now needed 3%. So in order to solve the same problem, they need to recruit. It's like you're walking uphill with a backpack. If I take the backpack away, you're going to walk faster. And that's the given, right?
Yep.
But if I put the backpack, one, you're going to be slower, and two, you may get tired more easily. So you may not reach to the top, while your colleague may reach to the top because he or she did not have a backpack. But it's the same idea. So what we're measuring in clinic may not necessarily reflect the underlying damage because we have redundancy. And that is one of the major problems with any study that is done. We do small cohorts, we measure cognitive or any other ability. Some people are going to be affected. Then you treat them, you do intention to treat analysis, and now you get that there's no improvement. And you say, well, treatment did not improve anything. But in fact, you were not powered because you need thousands of people to be able to actually find those that were affected. And only of those actually measured those that by treatment, whether it's reversible or not. So is there reversibility? Yes, there is. Is there the possibility to reverse? Yes. But completely depends on how long you went and how severe you were. And that is the second point. So it's important to do early diagnostics. And two, that the treatment will be as effective as possible because any residual disease will essentially perpetuate the system. You're still keeping the machine running, whether, it's maybe not as hard, but it's still causing a little bit of damage. And so maybe the reversibility may not be affected. So all this can be done in cells, can be done in animals, in experimental animals. You cannot do it in populations. So you end up with a very mixed bag of results that gets everybody confused, as anybody can argue whatever they want, and they will always be right. Oh, wait. That means that nobody knows anything. So that's that's the first point. So let's go backwards. So the second is, how do we detect? And what we're doing today is just taking a laboratory study. But in fact, we're talking about a syndrome, and not a single phenomenon. In other words, sleep disorder breathing is a vast spectrum of conditions, but more importantly, its clinical manifestations are what we call a syndrome. So taking Sir William Osler already said that in order to make a diagnosis of a disease, you need a very good history and physical. And that the laboratory should only account for 5% of your diagnostic. Now that was true for the diseases of then, but if you want to transfer this to sleep apnea or sleep disorder breathing, just taking a laboratory sleep study and say that's the diagnostic, and that's it. The rest doesn't matter. I don't think so. You have symptoms, you have functional issues, or you don't. So how do you put it all in the context of creating a package that will give you a more comprehensive, a more holistic approach to the disease and not just rely on a sleep laboratory and a number, the HI or whatever.
Right.
It's bogus. Come on, let's be bogus. Not because we don't want to know the severity. Of course we do. It's also the urgency of treatment. Dictates also whether we need to do more follow-ups or not follow-ups, alternative methodology. That's all very nice. But you cannot just rely on the laboratory, the sleep laboratory results to make and define everything that whether to treat or not to treat. That is a problem that, of course, insurances are going to opt one way, others are going to opt the other, everybody's going to find. So many years ago, Carol Marcus, when she was still alive in Los Angeles, defined the first set of normative data. We expanded that to almost 540 kids, normal kids, healthy kids, and found that there were some norms that we could apply by looking at the distribution of events. But the two important things came out. First is, this is only a guide that's to tell whether your test is within the standard normative variance. That's all you're going to use. There's 2 standard deviations beyond the mean, 3 standard deviations beyond the mean. You define what your want is. abnormal. That's one way of doing it. That doesn't mean that there's disease. All it means is that somebody has scored in that test a certain number that fulfills certain percentiles of deviation from the mean. That's all. You need to put the symptoms, and so we don't measure. And that's the big flaw of everything that we do in pediatric medicine. We do not measure morbidity. A patient comes to you and tells you, "Doctor, my child snores. Terrible. He's tired in the morning, grumpy, has bedwetting, I grind his teeth, and goes to school and sometimes falls asleep at school. He's okay, he's good, okay, average rates, A's and B's and occasional C. But everybody was like that in the family. So big deal." And you say, "Okay, well, you know what? Let's make a sleep study." And you take the sleep study and say, the kid has sleep apnea. Okay, let's treat. But have you really measured what has been the consequences of that specific kid? Has he lost intelligence? Is it IQ? Is it being measured? Does he have other functions of attention, of memory, of cognition? Can we measure those? Have we really used sophisticated methodologies that enable prediction of whether there's problems with the ability to think and problem solve beyond all that? How to do his endothelium? How's his vascular lining? How's it functioning? He's not going to have heart disease, but he may have a little bit of rigidity of the vessel, or he may have endothelium that is not very healthy. And if you keep it for a long time and you don't reverse it and pay attention to it, then instead of having a heart attack at age 50, you'll have a heart attack at 25 or 30. You could have prevented it.
Right.
You could have prevented it if you paid attention to these things.
And saw him say earlier, performed earlier diagnosis, and looked at the symptoms earlier in that child's life.
Start looking at the whole holistic presentation of the kid. Taking the laboratory as one of the indicators, and then make return on investment or ROI or risk management decisions that will say, okay, I'm not going to do surgery on a kid that has very mild symptoms, very mild disease based on whatever criteria I use, but I still want to treat and make sure that I minimize all of this as much as I can without conferring additional risk, such as surgery, for example.
Right.
So those are the questions that really need to be asked, and I don't think we ask them properly.
Yeah.
And so we have said, okay, tonsils and adenoid go out, that's the first line of treatment, and everybody goes to that bandwagon. Well, really? First of all, we showed, now, again, 12, 15 years ago, that only a third of the kids actually normalizes to 6 times.
Yep, the study with Bhattacharjee that you were involved in as well, right?
So, Dr. Bhattacharjee was my fellow at the time, so we were definitely involved. So, so an important component of this is that if you are giving treatments that do not have cure, and it's very tough to define cure for a lifelong disease. Remember, I said lifelong disease. If you are born with all the elements that predispose you to sleep apnea, the likelihood of you solving a disease just by doing one treatment it's non-existent.
Right.
Now, it may improve, it may actually normalize a certain laboratory test, but then over time, you're going to show it again if the circumstances are propitious for it to emerge again. So that's the second point that I wanted to point out. First, reversibility, is it possible, yes or no? Do we know enough about how to enhance reversibility? No, we don't. So we need to work on it. Second, how do we measure morbidity? Because that will define really the intensity and the risk-benefit ratio of any treatment that we do. And third, what are the mechanisms that lead to disease? Okay. So some of them have to do with craniofacial, neuromuscular, respiratory control, many other factors, right? Inflammation in the airway, narrowing of the airway, the tonical factors. So now you put all of this together, well, maybe somebody will have small tonsils and small adenoids, but then they have a relatively mandibular retrognathia that is small mandible with a high arch palate and all these others which predispose to a collapsibility of the airway. Or they may have neuromuscular features, or the control of breathing may not be necessarily a very good one and therefore the response to this, or your reversibility may not be very good. So now you are going to have to put all of these, and the adults have called this endotyping.
Yep.
Okay, endotyping in children is now beginning. It's probably going to be different than adults, and I want to remind everybody that children are not little adults; they're different. And so I think that that's an area that we need to again put in a lot of effort and start doing endotyping in ways that define with very large cohorts. What are the clusters? And today with machine learning and with all these artificial intelligence techniques, in explainable learning, we really can do very nice work at clustering. Now we did this 2012 when we did a clustering effect on a very large cohort of children, and we found 6 different phenotypes. 6 different phenotypes just based on polysomnolence. Children came with all of the same symptoms, snoring, everybody came for the same reason. And yet we had 6 features in the laboratory of the sleep study that could define the groups of being different. Now, some of them we expected, some of them we didn't really know what to do with them. Well, what does that mean? Now move forward, and now we have had studies done with my collaborators at the University of Valladolid, where we've used thousands and thousands and thousands of recordings, and used the recording only of the sleep study to define phenotyping, clinical phenotyping, and 2 things have emerged. One, there's probably a lot of many phenotypes. So now it becomes complex. What does that mean? How do you do
Yes.
it? Second, you can predict reversibility of the disease. In other words, can it be cured or normalized, yes or no? Which is interesting, just by knowing what the diagnostic sleep study is. And 3, if you use some of the physiological recordings of the brain or the vasculature, you can actually predict morbidity too. So there's a lot of information embedded within the sleep study that is currently not being determined at all. In fact, gives you some degree of the phenotypic morbidity and predictability of the response to treatment.
Yep.
So if we know that, isn't it time that we start really thinking, okay, let's understand the mechanisms of disease?
Right.
The mechanisms that lead to this? This is where multidisciplinary work needs to happen. I know nothing about the growth of the matter. Not that I know nothing. I had to learn from my colleagues, right? But when I went to medical school and my dentist friends were learning about the embryology of the mouth and the oral cavity, that was not exactly something that I was very interested in. Understanding what are the determinants of that growth, the proportionality and the function, and bring structure to function relationships, and understanding how these play a role is going to be terribly important by adding on other factors. Reflexes, neuromuscular reflexes, by adding what happens when you superimpose additional elements such as lymphatic tissue, lymphoid tissue, that grows in different ways. And, we proposed, again, in 2004, that the viruses, respiratory viruses, were a major determinant of safe disorder breathing in children. We showed that respiratory syncytial virus, a virus that affects almost everybody, has a memory effect on lymphoid cells. And if you are a certain type of unique immunophenotype for atopy or so on, your memory effect of that exposure to RSV very early in life will actually trigger a very explosive growth during any other subsequent infection of your lymphoid tissues to cause you to start having snoring sleep apnea, and then perpetuate that inflammation in the airway so that you continuously have a very heightened growth of the lymphoid tissue, which then shows you that you don't breathe well through your nose, therefore your mandible doesn't grow very well. So you can see where things are, oh my God, so sleep apnea is a viral disease. I could argue that. I'm not saying it is, but I'm saying that you can see where, depending on the perspective, the optics of anybody looking at the pathophysiology, if you're an orthodontist, you're going to say, hey, it's obviously because of the palate and the way that the dental arrangements are and the mandibular maxillary positioning. Okay, cool. And I don't disagree. If you are a virologist, you're going to say, well, it's obviously respiratory viruses. If you are an immunologist, you're going to say, well, I'm sorry, guys, it's all about the immune response. Okay? If you are a neurophysiologist, you're going to say, no. The nerves that control the muscles are the ones that are actually the response, and the central elements are the ones that define it. If you are a respiratory physiologist, you see, the coordination of the upper airway of the musculature has to do with a variety of chemosensory responses. So who's right?
Right. And that gets to such an important point of where this concept, a couple of the things that I find and I struggle with when I see this, the AAO recently came out with an update to their white paper. And one of their major conclusions was that children will outgrow sleep-disordered breathing. And they literally said primary snoring and mild sleep-disordered breathing do not appear to be strongly associated with progression to more severe SDB.
But that's the wrong assumption, because I will tell you, okay, let's say that you had snoring and, no other consequence. Okay, so you had snoring, and it showed that you had snoring during the period of your childhood. I will bet you that if you become a 30-year-old who gains weight, you will have CPAP. So did the disease really disappear?
Right.
Or just did not manifest itself for a period of time because the conditions were not right? You were doing sports, you were lean, you were athletic, you did other stuff, you were not exposed to environmental pollution, you were not exposed to viruses, you were lucky enough that went back into silent phase. And only now at age 35 or 40, when you gain quite a bit of weight and you have full-blown sleep apnea. Is there a connection? Actually, there is. But there is.
Plus the comorbidities along the way, that the cardiovascular, behavioral, right, neurocognitive, that may not show up. I mean, the second best hypothesis, right? When does it show up? How far up that hill with that backpack does it start to set in, right?
Or not.
Or not.
Right. Born with an IQ of 150 and you lose 8 points, nobody will notice.
Yep.
But if you're born with an IQ of 100, which is the average, and now you lose 8 points, that's really makes a huge difference. So it all depends how lucky you were to start with.
Yeah, no, that's a great point. And I know you're going to have to run shortly, but one thing I want to touch on too is, before we finish, is this whole progression of disease. There is a big debate within the orthodontic arena of whether mouth breathing is a thing chronic mouth breathing, not when the child's acutely ill or running, say, but chronic mouth breathing, especially at night, is a problem. And whether that can lead to, and I know there's a bunch of literature within the medical literature, some even new, stating that it does, in fact, lead to more severe disease in many patients. What would you say on that to those orthodontists who are out there, even dental colleagues, and say, mouth breathing's no big deal. It's really nothing we should worry about. Much ado about nothing. And don't really worry about the patient until they have a PSG with an AHI of 1 or more.
Well, there's somewhere in between, okay? And let's go slowly. Let me see if I can make a little bit of more sense into what I call a compromise, diplomatic compromise.
Okay.
Because I can understand both opinions. Mouth breathing, oral breathing, with chronic mouth breathing will lead to dryness of the mouth. And then all the microbiome is going to be modified. The changes in the microbiome will likely modify, and we have some evidence that they will modify to more pathogenic type of bacteria or microorganisms that in fact may promote under a low-grade inflammatory immune response in the level of the airway, right? Which then is prompt to be much more explosively grow during a virus or during whatever it is. You have an invasion, so we know that mouth breathers are more likely to have respiratory symptoms as children. Go to primary care for respiratory symptoms. So that's an interesting proposition, because if they're exposed in the same daycare, in the same thing, and one of them goes more often to the respiratory to the pediatrician because of respiratory symptoms, that means that this mouth breathing could be one of the underlying factors that promotes that susceptibility to upper airway disease or respiratory disease. So that shows you that maybe it's not such a good thing. At the same time, can you claim that having oral breathing or chronic mouth breathing, being a chronic mouth breather is going to progress to sleep apnea, I don't know that I would make that strong difference, but with a caveat. So let's say for a second that you are a chronic mouth breather, you have these changes in the microbiome, you have a little bit more of inflammation in the airway, and now that inflammation is going to release cytokines. If you take an isolated airway of a rat, okay, we've done that experiment. We haven't published it, but it's done. Took an isolated airway, which is by the way, the rat does not have sleep apnea. It doesn't collapse the airway, okay? So you take an isolated airway and you drop cytokines on the airway becomes more collapsible. So if you have chronic inflammation with cytokines, inflammatory cytokines, that are circulating in the surface of the airway, maybe the collapsibility of the airway will be increased. So in a way, if you are predisposed by craniofacial, neuromuscular, and all the other time, and now you add a little bit of a burden called cytokines into the airway by virtue of being an oral breather, maybe that's going to make you more susceptible to sleep apnea. Now, will it evolve? I don't know. The theory of evolution has been driven by two major observations. One is in adults, that as you progress through the night, the severity of the AHI will go up. There's been early observations. Well, there's an explanation for that. We also change state. We go more from non-REM to REM. So how do you account for that is a little problematic. So the studies may not necessarily reveal what it is. The second is, it's a phenomenon that we have shown as well in children, that if you start elevating CO2 intermittently because of your increased upper airway resistance, then you tend to change the pattern of respiration. And what you do, you start driving more tidal volume and less frequency, which means that your negative inspiratory pressures are higher, which means that your collapsibility will be a little bit higher. You're driving more, therefore, if you have a collapsible segment, it's more likely to collapse because you're pulling more strongly, right?
Starling resistor, right? The concept.
Using the Starling resistor method. So if you have nasal occlusion and you have a collapsible segment, and now you have increased also downstream, not only upstream, downstream negative pressures due to using more of your tidal volume rather than your respiratory rate, then that will also favor the collapsibility of that segment. So yes, it's possible that it is true, but I would not make, it's the only explanation. Okay, so a little bit of both. Yes, there might be some truth to it. Now, is it better to breathe through your nose? Yes. You filter the air better. You have less, your breathing and your cardiovascular system and your vagal system is better recruited. Yeah, you have a lot of advantages by nasal breathing. Is it always possible? Not necessarily. Because if you have chronic allergic rhinitis, what are you going to do?
Right. Which I think is something often overlooked. We don't, in the dental world, when I speak and lecture on this, that's one of the things so many people say to me afterwards, well, I never thought about that part of it. They think tonsils, they think adenoids, they think high vaulted palate, insufficient tongue space, maybe a restriction of tongue mobility by freedom attachment. But when I talk about the fact that there's estimates of 40% of children suffer from some sort of chronic allergic rhinitis in the US today, they're like, and that we're seeing a lot of these patients come into our offices that can't breathe through their nose, and we don't take that into account oftentimes, and it's such an important one.
And it's difficult to reverse, right? And so I would, again, I want to believe that having a multidisciplinary, a multifaceted approach to the patient is really essential in order to define better, by virtue of the tools that each of our professions has developed in the context of our unique areas of interest, bringing them together and quantifying this into what I call reader plots. So quantify each of these elements and then look at the design that you get, and that's going to be the phenotype or the endotype of your patient. Now that you have that, then treat that. Do not treat somebody else. Treat that specific one. That's the important part.
Right. Yeah. I love it. I'll let that be the last word with it. I often say the etiology is multifactorial, so the solution needs to be multifaceted and usually multidisciplinary. And
Absolutely.
I think if we all just kind of look at it that way and realize it's way more complex than what we oftentimes think, and we can't distill it into one phenotype or one presentation. It's multifaceted, and we don't think about the morbidity, and we don't think about the reversibility. So thank you for taking the time to talk about that in great detail on the medical side. I know this is going to be a tremendous help for the listeners of this show, and I can't tell you how much I appreciate you taking the time to come on and share this message.
My pleasure, Michael. Always a pleasure to see you, and have a wonderful day.
You as well, Dr. David Gozal. Thanks so much for coming on the show. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERT recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.